This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV. This Week in Virology, episode 785, recorded on July 26th, 2021. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from New York, Daniel Griffin.
Hello, everyone.
Thank you, Daniel, for agreeing to this special episode where we will try to make inroads on some of the backlog of the email that's sent to you. We only do 3 or 4 on your weekly updates, so I thought it might be a good idea.
Yeah, I think, Vincent, every episode with you is special. Just want to throw that out there.
Thank you.
I think that what happens is when we don't get through enough, I start getting ones just shot directly to me, like, hey, I hadn't heard back. And thus I'm hoping that by doing this is going to help everyone and answer all those direct questions.
For this week, but they really pour in at a high rate, and this is just a fraction of all of them, but let's make some inroads.
Okay.
First, though, Jennifer writes, "Hi, Dr. Griffin. I enjoy listening to the quotes you share in each clinical update, and just encountered one I thought might resonate with you during the pandemic moment in which we find ourselves. Quote, 'Nobody can go back and start a new beginning, but anyone can start today and make a new ending.'" And that is from Maria Robinson. Jennifer writes, "The provenance of the quote is uncertain, but this is how I encountered it in the book Unwinding Anxiety," and she provides a link for that. "With all good wishes and appreciation for your helpful updates."
Oh, thank you. That's a great quotation. And I think that I'm just going to say yes, because, there was a lot and there has been a lot of, what went wrong. The only point of looking, I think, at that is what can we do better the next time? What can we do better going forward? And hopefully everyone will embrace that. And this will be about, the next 12 to 18 months. How can we do a better job? How can we learn? And I think I called out on everyone last time. I'd like all your help. Let's all work together. Let's be part of this.
Sarah writes, "On Friday, you said chance of death in unvaccinated 1 in 30, chance of death in vaccinated 1 in a million. I find this a very compelling and reassuring thing to tell people about how great vaccines are in light of the inevitable breakthrough infections. But I first want to understand the numbers it is based upon. For example, is this of people who test positive or some other categorization? Is there a particular data source? Take care, Sarah."
Yeah, well, thank you, Sarah. Actually, let me put that in context. I'm really, when I throw those numbers out there, I'm looking at case fatality rates. And we've talked about a 2 or 3% case fatality rate. So if we use the 3%, it's about sort of a 1 in 30. We know that that's a little bit off. When we talk about the infections that result in death in vaccinated people, again, we're talking numbers again where we say, okay, about 300 million people vaccinated, about 300 deaths, 200 million vaccinated, about 200 deaths. So it's all sort of, crude ballparking. I feel like, when someone dies of COVID, we have a really good numerator, right? That person died, but the denominators, that's something we always struggle with. So these are ballpark. Is it 1 in 30? Is it 1 in 100? Kind of in that range. The deaths in someone who's been vaccinated, is it 1 in a million? I think we're rough ballparks, and that's where I'm basing that. And you can look at several sources. The Worldometer is really nice. I think World O, my Brooklyn accent kicked in, the Worldometer. But and the Hopkins. So there's a number of tracking where you get a rough sense of the case fatality rates, and that's what I'm basing it on when I use those numbers. But I think I'm also going to say, think about the same thing in different ages, different vaccine side effects, because at this point, COVID's becoming endemic. So your choice is, what's my risk if I get COVID versus what's my risk if I get a vaccination.
I also don't particularly like this word breakthrough, because the vaccines were not, as you know, Daniel, not tested to prevent infection. They were tested to prevent disease. And so breakthrough makes them sound like they're failing, but they're still preventing severe to severe disease, right? So
Yeah, you noticed I didn't use the B word. That's one of the things in my house. We don't use the
Good.
B word in this
Good.
house. It's misleading. It's like the T word, right? Um, so, language matters. And I think if you're
Hmm.
careful with your language, you know what you're talking about. And if you know what you're talking about, then you can respond appropriately. If you're sloppy, then people, I think in this sense, they get worried. There's fear. Why would I bother getting vaccinated if I might get a breakthrough infection? So yeah, the B word is not a good word.
All right. Julie writes, I live in part of rural Colorado where rates of COVID are very high and hospitals are full. The county vaccination rate is about 30%. Misinformation is rampant here. Yesterday I met a parent of a student at my daughter's school who told me she knew many people who had died from the mRNA vaccines. She also told me she recently had gotten COVID and cured herself by taking ivermectin. Neither she nor her son will be getting vaccinated. The school administrator told me there are parents who do not want their children around vaccinated kids because they believe the vaccines will give their kids COVID. Virtually no one is wearing masks and everything is open. The same day the CDC came out with guidelines for school opening, our county came out with their own school reopening plan. No vaccinations of any kind required, no distancing, masking, etc. There will be no remote options for any students. My family is fully vaccinated, including my 12-year-old daughter, and we have no underlying health conditions. Still, I'm struggling with how to navigate school for her this year. She's had a year and a half with little social interaction, few opportunities to develop friendships. According to county data, about 14% of 12 to 15-year-olds in the county are vaccinated. Would you send your child to school under these conditions, even fully vaccinated? Is it worthwhile for her to wear a mask, even if other kids are not? There are social consequences for masking at school. I would greatly appreciate any advice in navigating this situation. I'm finding it more difficult than last year because I feel alone in my concerns.
This is very upsetting what you just laid out. And I know our Surgeon General, went public saying misinformation is now one of the top health threats. It's amazing to me that, years ago that this wasn't realized. And with that statement, it was not followed up with, and by the way, as part of our stimulus package, we're going to really double down on science communication. We're going to really double down on informing people. It's just like, yep, this is a problem. And what you're describing is the fruits of that problem. That's a blatant lie, right? This woman saying she knows lots of people that have died from the vaccines. Really? We monitor this very closely. That's just not true. The other thing, and I think this just really troubles me, is the other lie, which, it's not a big deal when a child gets COVID. It is a big deal. It's a big deal if you're a child. It's a big deal if a lot of children in a school get COVID. Yeah, they're probably not going to die. They're at low risk of ending up in the hospitalization. But what about being sick for 2-3 months? I was just chatting with some of our sailing instructors this, recent weekend. We did a big charity regatta. And one of them, was saying, you know what, I was very athletic, but when I got COVID, I still can't run. And it's been months. And then a couple of the others started chiming in with all the residual symptoms they had since they had COVID. And these are young kids. These are kids about 20 years old. When you're a little younger, maybe the rate is a little bit lower, but I don't want my child to go to school. I don't want my child to be in an unsafe environment and potentially be sick for months, have trouble concentrating. We don't know how long that's going to last. We already have data on kids saying that this can go on for months. I have to say I was pretty upset this morning. I saw like a New York Times thing in my inbox about how, really not a big deal when kids get COVID. Are you not a parent? And so, you are in a tough situation. Would I be comfortable sending my 12-year-old vaccinated to school in that situation? No, not really, actually.
Laura writes, thanks for the episode and your ongoing positive attitude. I'd been inspired by many things recently, and today your quotes from Juliette Gordon-Low made me reach out to my unvaccinated friends and try and be the inspiration. I've been unable to talk to them or see them, due mostly to my anger at their attitude and seeming selfishness, plus some fear for my health and theirs. My family and I are all double vaccinated, but I am also an ER and family doc and have 2 nieces who are too young to vaccinate, and their mom is highly COVID nervous. My question is, am I being overreactive about not seeing my friends? I have now offered to walk with them and listen to their vaccine fears, and will try to direct them to TWiV and the open forums if they will go there.
So first off, thank you for sort of taking that, embracing that, and starting to look at, can you cross that line? I'm not sure how this happened. Growing up, right, I was always told, there's a couple things. You don't discuss religion and politics, and I guess now vaccinations. But we did anyway, right? That was what people wanted to talk about. And there was much more of an intermixing, and we've become really separated and tribal, and we won't spend time with people that disagree with us. Well, you could spend time outdoors. You could spend time about 6 feet away from individuals with different views, but having open lines of communications, because I think, unfortunately, for a lot of these individuals, they are victims, as we now know, of this multi-million-dollar misinformation campaign. People are getting rich off misinforming these people. There's a lot of money. It's felt like it destabilizes trust and authority. This is horrible. And a lot of those people are victims of a multi-million-dollar marketing disinformation, misinformation campaign. So I think it's important to have the conversations. We've got to keep having those conversations. That's the only way we're ever going to come back together as one nation. So I applaud you for wanting to step up and do that.
All right. The next one from Madeline has two occurrences of the B word, which I will try to substitute. Daniel, I lead the testing program at a large university. We are seeing increased cases as others are nationally. Over 50% are in vaccinated individuals. Viral loads in these cases are high. CT's under 20. Is there any quality data on viral loads in vaccinated individuals? These would appear to be very infectious cases.
Yeah, so that's one of the challenges, and Vincent and I have talked about this quite a bit. Is we don't have as much data as I would like with changes in the sequence of the spike protein, looking at vaccinated, non-vaccinated. So what do we know actually? We talked back, I think it was beginning of July. Wow, this month, I think it's like right around July 4th, the July 4th weekend, about the fact that there was a study in the UK that when people who are vaccinated get infected, it looks like about a 50% reduction in transmission after that first vaccine. It's sort of an epidemiology impact. And then we actually talked about another paper, the New England Journal paper, and this was prevention and attenuation of COVID-19 with the mRNA vaccines. And this was suggesting that there was actually a lower RNA level, a shorter duration of that RNA being detectable. But we really need the data. We need to look at infectivity assays. We need this done in a BSL-3. It would be nice to know, for instance, we talk about our Olympic athletes who are being tested all the time. And then they're pulled out of the events. And if we could have a really better real-time sense of what is an infectious level, what is not, I would think of a CT value as less than 20. That would in my mind, be associated with these positive culture assays. But we also know timing matters. In the first 1 to 3 days, that looks like that's when you're getting the contact tracing hits that we see. But we need data on vaccinated people. We don't know. That's just an RNA level. It's not all the data we need to make these decisions.
Scott writes, I'm a Maine primary care doc who has written to you before. My daughter, a 29-year-old artist social worker, lives in Queens, flew here to visit us Friday evening 2 days ago and mentioned briefly, barely, quietly, right before we went out to dinner here in Maine, she thought she might have a slight cold. I'm sure you know where this is going. I tested her in my office with a rapid antigen test. She was quickly positive twice. We have all been vaccinated with Pfizer. I'm assuming she has the Delta variant. I'm writing for two reasons. First, despite having Lynch syndrome and celiac sprue and a few other autoimmune problems, she's not a candidate for monoclonals. However, being an anxious father, I called around speaking with ID docs here in Maine and a couple of different hospitals and EDs. Just as an FYI, nobody knew much of anything about monoclonals. Even my local, very nice and helpful infectious disease doctors who mostly takes care of inpatients. Some of the ER docs and nursing supervisors and pharmacists had not heard of them and asked me only if I meant remdesivir. The Maine CDC, who I contacted to do my due diligence, told me that monoclonals are only used for inpatients. I corrected them. Eventually, I did find one outpatient facility 45 minutes away where the current monoclonal cocktail is available, just in case my wife and I get sick. Second, I wrote a letter yesterday and sent it to the Portland Press Herald and New York Times, mostly about the experience and about the Delta variant and vaccinations. I think I plagiarized your line. Vaccinations are how we will end this pandemic. I think it's your line, but I'm not sure, so I thought I would turn myself in. Thank you. The letter probably won't get published, but my work partner and I still depend on your podcasts.
No. So, I was just on a call with John Hitt and a few other clinicians, non-clinicians that we meet with on a regular basis to discuss kind of the national landscape of what's going on. And one of the questions that came up was what's going on with monoclonals. And we're really lucky, I have to say, in this in the Northeast region here. We are really using monoclonals a lot. We have excellent access. We've partnered with the Catholic hospitals so people can just, phone call away. You say, here's where you need to go. A few hours later, they've gotten their monoclonals and they're back home. One of the large healthcare systems, they can schedule and get it done within a day or two. But that's not true in a lot of the country. And part of the thanks was we actually partnered with a lot of groups. We partnered with Survivor Corps. They put stuff up on their website, helping direct people. But a lot of the parts of the country, you're experiencing what you're experiencing. And again, didn't we just hear about the importance of communication? It's not just a question of misinformation and disinformation. It's a lack of information. When someone gets COVID, when a physician is called about a patient that has COVID, you kind of want everyone educated up to the point that that patient is getting the best possible therapy. So appreciate you bringing this to my attention again.
It's really remarkable, the disparity in knowledge across the country, right?
It really is, actually. Yeah.
We here are privileged in a way because we're hearing about everything, but it's really stunning. Emily writes, I'm part of a group making decisions about COVID protocols for a nonprofit that hosts several events a week for medium-sized groups up to 30 people. We're in a county where the CDC says current community transmission is low, but all the counties surrounding us are categorized as having moderate community transmission, so I suspect our status may change soon. Right now, our mask policy is that unvaccinated people are asked to wear masks. If someone wants to come to an event who is immunocompromised or who medically cannot be vaccinated or who is too young to be vaccinated, we will have all present wear masks upon that person's request. Here's my question. Some members of my group think that we do not need to change our policies, even if community transmission goes up, because almost everyone who comes to our events is vaccinated, 95%, and because those who are not are masked. The sense is that vaccinated individuals can make their own decisions about whether they want to risk the relatively mild illness that comes with symptomatic COVID after vaccination. My sense is that there might be a threshold of community transmission at which we should require masks regardless, not because of the risk to individuals present, but because of the risk to the broader community if the virus is likely to be transmitting even from one vaccinated person to another at our events. What does the science actually say about this? To what degree are we introducing risks to the broader community now with rates of virus being low in our geographic area? To what degree would we be introducing risk to the broader community if rates go up in our geographic area?
Okay. I think one thing I'll sort of throw, and I think this is important to think about the efficacy of all the different interventions. So, when you hear, we'll use the Delta variant here. When you hear that the mRNA vaccines are about 88% effective, that's an 88% reduction. It doesn't mean 88% of people are fully protected or anything like that. So it's an 88% reduction if you put yourself in a certain context. You can actually look at what those contexts are. So when I go to the supermarket, and I'm actually in an area where there's a really high vaccination coverage, we still in our local area have a very low test positivity rate. I still wear a mask, and it's really a question in my mind of I don't really want to get a mild case of COVID. I don't want to be part of the transmission chain. I am not a huge fan of governments having to mandate. I actually think like education and people making wise choices is preferable. But I think you need to start looking at the concepts here. If someone is an older individual over 65, and maybe people coming to your venue are in that age group, that vaccination is lowering their risk, but it's not taking it away. they still could potentially get infected. They still could potentially spread it. There's a balance here that you're going to have to sort of look at. How much do we want to return to normal? What risks are people willing to take? Think of the bulletproof vest. Just because you have a bulletproof vest, you don't want to go out and let someone, test it out, shoot you in the chest. You're not going to die. It'll just break a rib or something. Maybe they'll even miss, think of it that way. An umbrella, if you've got a pair of fancy new shoes, you might wait till it stops raining. You might not go out on a rainy night. You might switch those shoes to a pair of sneakers. So think about everything. It all adds up. It's cumulative.
Chuck writes, what are your thoughts on the possibility, likelihood of long COVID complications in those whose infection to COVID-19 came after they were fully vaccinated? Would this data play a role in determining the need for masking in vaccinated individuals?
Yeah, I'd like to actually have numbers on that. I think it's important to have numbers to data to make the decisions. Now, I have not personally seen an individual who was vaccinated and then went on to have an infection, and then but again, think about time. This all takes time. So you got to be fully vaccinated, and then you've got to get exposed. You've got to get infected. You've got to get past that month, and then you have to be assessed for long COVID. So I'm starting to hear reports from groups like Survivor Corps, Diana Barrett, people like that they are having people who are entering these support groups with that history. Now, it's really hard to do a survey in that context because if you join the group, if you know about the group, you may very well have long COVID. There's a selection bias. It would be nice for us to know, we talked about that 1 in a million, 1 in 1,000. If you are fully vaccinated and you then go on to actually get a symptomatic case of COVID, you keep dropping your percentages at each level there, then what is your chance of getting long COVID? And I think that's relevant.
Alicia writes, hello, Daniel and fellow floating doctor. I'm an internist. I met you in Panama 2 years ago when you helped me with my presentation. As the pandemic has eased, I've thought of going back to Panama to work with floating doctors. I'm scheduled to leave at the end of August. Is this wise, given that Central America is a COVID hotspot right now? Would it be more sensible to defer a few months? And Alicia is 63, fully vaccinated, concerned about potential for exposure in enclosed spaces such as airport and airline cabins. I understand I likely will not get serious COVID. However, I would prefer no COVID. Can we quantify or ballpark risk in this scenario?
Well, nice to connect again. I remember our interactions fondly. We were actually teaching, we're doing a continuing medical education program together down in rural, remote Panama. So definitely go. You are a huge resource and you'll make a tremendous difference. But how can it be done safely? You point out the risk factors, the travel on the way down. So I think I've mentioned in the past that, when I travel or have my family travel, the KN95, try to, it's not that long a flight. So, eat and drink before you get into those crowded indoor exposure situations. Fortunately, right, floating doctors, you're going to be outdoors almost the whole time. So that's going to be helpful, reducing your risk as well. But, a lot of us, right, we know when we go to these areas, there's a certain risk that you're taking. But yeah, individuals like yourself, getting back out there doing this global work, particularly someone with your tremendous skill sets, I think this is really great, and I'm going to encourage you.
Alicia said the same you did. I'd prefer no COVID. Jen writes, my children were virtual for school last year. We live in a school district that gave two options, virtual or full in-person learning. As a multi-generational household, the choice was clear last year. My boys did great. All of us but my 10-year-old vaccinated, so we're planning for in-person school this year. Our school district has already said that masks will be optional for students and staff this fall. My son will certainly be masking. However, how much protection will this offer him if the majority are not masking? They have also said no cohorts and there will be no restrictions with music programs. He's in the choir. On the upside, as of right now, our community has had very low to no cases for the past month, and vaccination rates for adults 18 and up that completed their series is 64.5%. Total population completion of series, 53.7% in our county.
This is very painful, probably more painful for you than for me. We know how to open schools safely. We know how to provide safe in-person educational opportunities for the children. Um, it does sort of bother me that it sounds like a lot of school districts are choosing not to do that. And I think it probably comes back to this perception that it's not a big deal if kids get COVID. And as I think I've said several times, kids may be at low risk, but they're certainly not at no risk. And we do not know the exact numbers on how many kids continue to be sick for 2-3 months after that exposure, after that infection. But it's at least 2, 3, 4%. Some studies have said it's even higher. I'm starting to feel like it's even higher when I actually really start asking pointed questions and get into conversations with younger individuals. So it really bothers me. And I think I said before, parents need to go to those school board meetings. They need to advocate for their children. Your child should be able to get an education, but in a safe way without them having an undue risk of getting COVID.
Eben writes, I'm a cultural anthropologist. Right now, SARS-CoV-2 is hitting the area of the world where I work, West Papua, Indonesia, and is hitting hard. It's not in the news, but people are lining up in the streets outside clinics, coughing, with classic symptoms of not being able to taste and smell. I'm writing because there's a lot of anti-vax sentiment circulating, and I'm about to participate in a public forum and want to pass on the most accurate information. Sinovac is the only vaccine available. Actually, Eben then writes later to correct that. So for starters, I'm trying to convince the public that this isn't new technology like mRNA, where there may be some unknown effects in years to come. I found one early press release from Brazil suggesting that Sinovac was the safest of all the vaccines tested in their early trials. Any updates? Also, medical professionals in Indonesia are asking people about their pre-existing conditions before they're offering people vaccine. Do you know of any pre-existing conditions that would make you think twice about giving Sinovac? Are there any significant adverse events that people should be aware of? And then he sent a follow-up at a public event. Dozens of people are writing him with questions and more information. The nurses are, this is pre-existing condition, sorry, but he says, it turns out AstraZeneca is also offered, not just Sinovac. I know about the rare blood clots with AstraZeneca. In your opinion, is there any reason to recommend Sinovac over AstraZeneca, or should people just go for whatever is available?
Yeah, so the Sinovac is traditional technology, right? It's the inactivated virus vaccine. And so this has been used for decades. So it's nice to have that as an option for people who have a certain concern, maybe about newer technology. Actually, I would love here in the U.S. if we had more options. Really waiting impatiently for the protein subunit, the Novavax. Just another. Let's use something that's been out there for a while, so that at least if that's what's holding people back, we've got an option there. I always say take whatever vaccine you're offered. You're splitting hairs in a lot of ways between vaccine efficacy if you're looking at Sinovac versus AstraZeneca. Then I'm going to talk about the issue. Is there, the pre-existing? I sometimes feel like people get in a routine. Like I noticed this at some of our Moderna clinics. The nurse would run through, and I was like, well, what are you doing? Those are, are you allergic to eggs? Like they start sort of getting in I'm doing vaccinations, so I'm going to ask the questions that I always ask. The question I ask people is, which arm, and are you a bleeder? So I know if I need to have a Band-Aid ready. And that's all you really need to know.
Yeah, because Eben had listed a whole bunch of things like TB, malaria, high cholesterol, heart disease, reflux, joint pain. He wants to make sure, because he's not a doctor, but his gut feeling, just get the vaccine, right?
Well, I think you also, if you start asking, you just turn what could be, a 20-second process into, much longer. And when you turn it into much longer, less people are getting vaccinated. I talked on one of our last TWiVs about, just getting the vaccine there is part of the process. You need the syringes, you need the needles, you need the staff, you need the facility. Well, staff, facility, time is money in these such situations. So ask questions that are relevant. There's not a lot of questions that are relevant for a person getting a vaccine or not.
Back in February, I was only asked, have you ever had an allergic reaction to a vaccine? That's it. And which arm?
That's good.
Michael writes, I have a patient with lymphocytic colitis and fibromyalgia. She'd already been twice infected with SARS-CoV-2, was reluctant to get the vaccine, thinking she was already fully immune. Based in part on my advice to her that vaccine-induced immunity was more robust than a natural infection, she finally got vaccinated so she could attend a college that required the vaccine. Upon getting the second dose of Pfizer, she developed severe back and neck pain on the side of the injection that lasted for over a month. She was evaluated in the ED twice and had a brain MRI, all coming back without any significant findings. She finally recovered with the help of a physical therapist. Does a pain condition like fibromyalgia or inflammatory condition like lymphocytic colitis sensitize people to adverse effects of the vaccine? Should someone who had already had 2 natural infections get the vaccine, or is the second infection enough to boost the response on its own?
No, so these are excellent questions. The first thing I'll start off with is, if there was no SARS-CoV-2 circulating in the world, we would not need to get vaccinated. So the decision to get vaccinated is protecting you against potentially getting infected, or in this case, reinfected. We definitely, as you described, we do see adverse events. I'm glad that this individual finally recovered. Hopefully they're still talking to you because you are advising them in their best interest. But no, these things do happen, and I think it's always been important. I know when the J&J paused, a lot of people were upset. They're like, just keep going. You don't need to. And I was like, no, we need to be honest. We need to be transparent. We need to tell people what can and cannot happen. But now here's your last question is, what about someone who already had COVID-19? What about someone who already had it twice? Do they get 1 shot? Do they get 2 shots? Do they even need to be vaccinated? And I've talked a little bit about sort of the 3 levels of data we have. The data suggesting that the B and T cell responses from natural infection do not look to be quite as durable and robust as vaccinations. Also, some of the data we have on infections in people who've been infected before. I mean, this perfect example. Here's an individual who got infected. They got infected a second time. And then I mentioned my personal experience. We are seeing more individuals as time has gone by who were infected early in the pandemic, now coming in with a new infection. So we still recommend that a person get the full vaccination series based upon all these bits of evidence. And I always like to point out, this was a terrible reaction. This person didn't feel well for a month. A third infection, what could have the outcome been there? So I think you did the right thing by encouraging them to get vaccinated, and I'm sorry they had such a difficult time.
Michael feels that by listening your show every week, Daniel, he's completed an ID fellowship on COVID. All right, another Michael writes, now this is a disturbing letter where Michael first talks about his wife who was concerned to overhear their pediatrician, they have 3 children under the age of 12, saying things which disturbed him, like he related a story in which he told his own 23-year-old son who works with vulnerable adults not to get the vaccine, even though his son's friends were bullying him to do so, agreed with an unmasked mother who, it turns out, works in a local hospital and is not vaccinated, that it was unfair for her hospital to tell her to get vaccinated, and she was right to keep her teenage daughter unvaccinated. Brought up a news story about a college student who had been denied medical exemption for COVID vaccination at BYU, Hawaii, despite having had Guillain-Barré. And we'd had previous concerns about this pediatrician. He'd not worn a mask during a well visit, etc. So the question is there anything which can be done to limit damage from pediatricians and other trusted medical professionals who spread misinformation about COVID vaccination to their patients? I don't want to give it up as a lost cause, but it does feel a bit hopeless when somebody who should be one of the most informed acts as though they are one of the least.
Yeah. Number one, I'm not sure why you're still seeing that pediatrician, to be completely frank. I mean, if this person has gone through this amount of education and they're still left making comments like this, it is long overdue for you to switch healthcare providers. That's just horrible advice. Not only is it horrible advice, but they're not doing this just as a misinformed individual. They're doing this with the mantle, And so the American Academy of Pediatrics has been very clear in endorsing vaccines. So here's a person who's just, in a sense, going rogue and encouraging people in settings where when they're unvaccinated and get infected, they're going to put other people at risk. Really just horrible here. This is stuff that we probably need to do a better job of continuing education for, so that we don't have individuals misinformed like this, spreading that amount of misinformation.
Linda writes, now her letter is about her husband's 101-year-old mother. And this may not be in time for them because it was over 6 days ago, but it might be useful to someone else. She developed a cough, sniffles, and fatigue on Saturday. I had just listened to your clinical update that mentioned you had a colleague who had experienced an uptick in positive COVID cases. You mentioned Everett, but I do not know if this was Everett, Washington. Based on your comment, we suggested she get tested. Today, Tuesday, her test came back positive, but monoclonal therapy was not recommended, even though her case is mild. Since she is 101, would you suggest she ask for this therapy?
So I don't let vaccination status influence my recommendation for monoclonals. It particularly a 101-year-old person, there's what we call immune senescence, right? Our immune system is not as robust when we get into our later years. I think we were talking on a call today about, when you looked at the adolescent studies, there were no positive PCRs. I mean, really, a young person has an incredibly robust response to vaccination. So 101-year-old, these are the individuals that can get infected despite having vaccination. These are the individuals that end up in the hospital. These are those individuals that have that increased risk of not surviving. So a symptomatic COVID case in a vaccinated individual who is at high risk for progression, like this individual, I would recommend monoclonals. The clinic actually is Everett, Washington. So it's the Everett Clinic. And my buddy Poe is out there. And we were actually talking about monoclonals today and just discussing this issue.
Amy writes, I'm a senior microbiology major at Mississippi State, planning to get my MPH after graduation. My mom often finds, quote, information, unquote, from Facebook about COVID-19 and shares it with me, but won't listen to the things I share with her that come directly from clinical papers or the classes I take. Basically, she keeps talking about booster shots for the COVID vaccine. Could you give any input on the timeline or need for booster shots? Thank you so much for your commitment to public health and safety.
So the science is still not here, and that's what we're waiting on to determine if, and even if booster is the right word here. Is it booster, or are we going to get an updated vaccine that has a specific variant or a polyvalent component there? What we do know is that we have observed the vaccines and the efficacy out to a certain period of time. It would not surprise me, just sort of our understanding of immunology, if there are certain populations, like we talk about the elderly, the immunocompromised, is there a certain point when it may be beneficial for them to either receive a third dose of the original vaccine or to receive an updated vaccine. But again, we always put this in that context of, you look at areas like Africa where 98%, including hundreds, thousands of healthcare workers, haven't even gotten a first vaccine. When the science is here, you'll hear about it. Social media, they don't feel like they need science to comment on something.
Paul writes, I have a 5-year-old that will begin kindergarten this upcoming school year. To our surprise, the school district has made masking optional for each family, although the entire population will be under 12 and not vaccinated. Our current metrics are approximately 1% test positivity and 15 cases per 100,000 within our district boundaries. The district has stated they will bring back mandated masking among students if community spread increases too much. They have not been forthcoming on the metric they will use to signify the crossing back into masking. My question is, there a level or threshold that you would consider safe for unvaccinated students to gather indoors without masks for school?
This was something I discussed on one of our recent clinical updates, which is the American Academy of Pediatrics, who I think appreciate the impact of COVID on children. Surprise. and saying that, for the safety of these children, and really the focus is on the long-term impact of COVID, the long COVID, the post-acute COVID syndrome in these kids, is recommending masking. I would recommending masking across the board. There's a balance here, right? I mean, kids learn better when they can see another individual's face and mouth. They can hear better without the muffling of the mask, et cetera. So I'm not saying that without that considered. But in a sense, are we going to wait until it's too late? Are we going to wait until we start having transmission in the schools before we do something about it? Because we know that's going to happen. And so when is the right time to wear masks? Are we going to wait till it's too late? Or are we going to start going into it with the mask wearing? And again, this is sort of my call to arms for the parents. You got to go to these school board meetings. You got to be as vocal as those individuals who are, decrying the need for freedom, et cetera.
Kevin writes, like many others, I have not traveled at all outside of my state for over a year now, but I'm now gearing up for a 3-month-long road trip in the western part of the U.S. I'm fully vaccinated, Pfizer, healthy and fit 22-year-old male. I have not been previously infected with SARS-CoV-2. On my trip, I will continue to physically distance and wear face coverings in crowded indoor areas, but I still want to plan for what seems to be inevitable for everyone at this point, getting COVID. What would your COVID survival kit look like for a vaccinated individual like me? An N95 to protect others in case I'm infected and need to quarantine, likely at a campground, ibuprofen, thermometer, rapid antigen test, tissues, other items?
The best thing you got going for you is your age, just to be honest. We'll throw vaccination right on top of that. So you're really getting that effective. You're basically an adolescent at 20. You have a good, solid immune system. The only thing in your survival bag that I like people to have is a pulse oximeter. You're at pretty low risk of progressing to a hypoxic level. But if your oxygen level gets below 94, that's when there's certain things we can do that are helpful. I think I mentioned on the last time we were recording that I was about to engage with the Gates Foundation, talk to them about their global COVID-19 effort. And so they were talking, what can you do with limited resources, right? It could be at your campsite there. If your pulse ox gets below 94, we've had experience here in the New York area. If you start the dexamethasone in those individuals, you can keep a certain percent of them from ending up in the hospital without ever having to prescribe oxygen or anything like that. You're at low risk. What you probably need is a good sense of humor, some good judgment. Make sure you look at your risk activities and just add a pulse ox to your kit.
Chris writes, this is a very interesting story. So Chris got her second dose of Pfizer on May 12th, and has about 2 weeks later started feeling great, which is weird because she hasn't felt great since her late 30s. She's 52 now, and basically at 41 developed CFS/ME. When most severe, she wasn't able to climb up or down a flight of stairs without crawling or using walking poles. Typical symptoms of CSF/ME. But after the vaccine, she said, and now for 7 weeks, she's felt great. And it's as if my large muscle groups are getting electric impulses have been missing for years. Given the sustained length of this mysterious improvement, the only thing I can think to chalk it up to is perhaps the vaccine jolt to my immune system having an unexpected salutary effect on whatever inflammatory or autoimmune issues have been experienced for so long. Does that make any sense?
Well, I will say that your experience is one that has been shared quite a bit. And we're still waiting. I'm still waiting. I feel like I'm waiting longer than I wanted to wait to get good data on what exactly is going on, what percentage of people are having this kind of a response. But we have had a number of people with the chronic fatigue symptoms getting better after vaccination. Sort of for me, making me wonder, as you suggested, was there an immune disturbance that somehow we were able to reset with the vaccines? Or maybe this was triggered by some other, virus or something, and we had a sort of similar antigenic impact. I'm not sure the mechanism, but I have to say you're not alone in describing this experience. So love to see a study of a lot of people with, CFS, ME, get vaccinated, and then see if this experience is as common.
Chris writes, you've been consistent in your message that school reopening can be accomplished safely. However, I heard Dr. Rosenfeld mention that the community spread of many respiratory diseases, influenza in particular, has a large contribution from school-age children. A casual search turned up a couple of pre-pandemic references that focused on the role of children in epidemic spread. Can you discuss how these apparently different points of view can be reconciled?
Yeah, what I've always said is that schools are a priority. They are an essential thing in our society. Schools can be open safely, but they can also be opened in a way that is not safe. So really, the trick here is opening the schools, but using what we've learned to do it in a safe way. And what have we learned? You're going to get about 80% of your reduction if you just get those desks about 3 feet apart, about 1 meter apart. That allows for most school districts the ability to get everyone back to the schools. Wearing masks, right? That's about an 80% reduction. Seems like a magic number here, right? So if you wear masks and you're 3 feet apart, ventilation is key, because when you're in these closed areas, even though most of this is large droplet, there's a certain amount that is smaller droplets that is going to circulate. So by having those air exchanges, having good ventilation, having open windows, these are all really helpful. So you can put a bunch of these things together, and you can actually end up creating a safe school environment where there are not exposure opportunities. And we have a lot of good science on this. So yeah, I think we can get the children back to school. I think we can do it safely, but we can also, as I'm hearing from some of these emails, some schools sound like they're going to just do it unsafely.
Charles writes, I've seen a lot of stories in the mainstream media about positive tests for COVID among Yankees and those at the Olympics who have been fully vaccinated. Being on the pedantic side, this drives me nuts, as the test is for SARS-CoV-2, not COVID. Using COVID makes it sound like the vaccines are not working. An exception as of late has been the Washington Post, and he gives a link. From what I've read, the Olympics are doing daily antigen tests and following up positives with RT-PCR. In some of the comments, people have asked about CT values. I know that Dr. Griffin likes to have the CT values, but if you have a positive antigen test, do you need them? My thought is no, you don't. My thinking is CT indicates if there's an active infection, but the positive test already tells you there's active virus. This led me to another question about treatments and testing. Does it make sense to do an antigen test to determine if a patient has active virus? It seems that if an antigen test is positive, antiviral drugs and antibody treatments would be very important to start. If the antigen test is negative, steroids and other treatments would be recommended. The antigen test would just be a more accurate, less subjective way to determine where the patient is in the course of the disease. Or is this way too simple or crazy?
No, and I think, and I'm going to say this is sophisticated, so I'm going to spend a little time walking through this with people. Now, early on, we were able to get some good data. I have to say, this data came out pretty quick. I remember like early March, Steve Goff actually sharing some of the PCR data with me. And what we see is this kinetics, where a person is exposed. There's a certain period of time after exposure when that person has been infected, but you cannot yet detect the virus sort of below a detection threshold. Then the PCR starts to turn positive, but at a very high CT value, a very low level of RNA. At that point, we're not seeing transmission. We're not seeing it in contact tracing go from one person to another. It takes about a day. And during that period of about a day, that CT value drops below 20. The RNA level is getting up into the millions. From our case control studies and our virus culture studies, that's when it looks like transmission is occurring in sort of this 2 days before symptom onset, right? Person doesn't have symptoms yet. And then for a few days after symptom onset. And at most, we say about 7 to 10 days after the symptom onset. And think of the slide at the playground, like it goes up, takes about a day, you reach a peak, and then it comes down over this, say, 5 to 7 days. We think there's a little bit of a shift to the left with the recent changes in the virus, where really instead of it being 0 to 6 days on average before the PCR becomes positive, it's now maybe 0 to 4. But on day 4, it's already up in the millions. And that's when we're starting to see transmission, or appears in our contact tracing. So if you think about screening, we screen the movie industry every night with lots of PCRs, thousands of PCRs, hoping to catch people who've been negative the day before in the high 30s before they've had a chance to transmit. With the Delta variant, it looks like you're already at an antigen detection level by that first day. You may not need the PCR. And then at the other end, I don't know if people remember, there was an individual by the name of Trump. And as he got to the tail end of his illness, as his CT values were dropping back down into the high 30s, his antigen test was becoming negative. So the antigen test is almost we'll say a poor person's PCR up front and a person's at the end, but maybe not a poor person, because it is giving us that sense that, okay, the levels of the RNA, the antigen, which correlates here, are dropping down below those levels. So, your PCRs, your antigens can help sort of target that window of when a person is transmitting the virus contagious.
Tamara wants to know if you can mix and match Pfizer and Moderna mRNA vaccines.
So I think so. So, and that's actually the recommendation that's come across. And if you think about the technology, I would say it's like drinking your soda out of a can versus a bottle. Very similar stuff on the inside. And if you go to a center and you say, "Oh, my first shot was Pfizer," and they only have Moderna, CDC, FDA has basically said you can go ahead, and that second dose can be of a different mRNA product.
Susan is asking about vaccinations and long COVID. During your update number 780, you mentioned some vaccinated individuals with breakthrough, the B word, infections did go on to get long COVID. You added the number is low compared to the number of people who have long COVID following exposure to the virus. Would you be able to be more specific in what you mean by relatively low?
Yeah, so my relatively low is, we see these. We certainly see a large number after the July 4th, I'm going to call it the July 4th surge, as opposed to the variant surge. A number of individuals were vaccinating, now testing positive. And we saw, a few in the spring. I haven't seen the 20, 30% that we saw with people who are not vaccinated. And as I mentioned, I've heard reports from Survivor Corps or Diana Barron. So I know it happens. It's definitely out there being described, but I just don't know how prevalent it is.
All right. Julie writes, all right, healthy, active, 37-year-old female, no health concerns, has been tested several times a week since September. In March, started having chest pain, discomfort, short periods of shortness of breath. Went to a doctor. COVID not suspected. Chest pain has continued. Experienced an episode of strong chest pain after the first Pfizer vaccine dose. Recently received a positive SARS-CoV-2 T-cell test from T-Detect, which I learned about from you. So I suspect I had a mild case in March, and this could probably be a lingering symptom. The pain was so bad on occasion I went to urgent care, had an EKG, nothing there. My doctor doesn't seem interested in helping me find answers. She said chest pain is normal and literally said good luck with that and sent me on my way. My question is, how can I find help determining if this is even a long-haul symptom, and then how to get medical help? Of course, I've been hearing lots about ivermectin, but my doctor told me it's super experimental and not something she recommends. I got in touch with Bruce Patterson at covidlonghaulers.com, but as soon as I realized I'd have to pay to be part of the research, I got suspicious. How can I vet this group? How can I get more information?
Yep. So this is an interesting story that you're giving. And I will say little subtleties on the T-Detect. The T-Detect, which is looking at the T cell receptor repertoire, is calibrated with their algorithm where the immunodominant protein is nucleocapsid. So a vaccination will not give you a positive T-Detect test. You need an actual infection with SARS-CoV-2 that has the immunodominant nucleocapsid. So you, at some point, had SARS-CoV-2. You had COVID. And then you got vaccinated, it sounds like. And it sounds like there was some chest discomfort, which may have actually been some degree of pericardial or myocardial inflammation. Now, this is the challenge. If you've had COVID and you're having symptoms later on, we don't have any objective tests to say, oh, we'll do this blood test and now we know. I'm working with a number of individuals, where we're looking at inflammatory markers that maybe they stay elevated, like a CRP or other things like that, that might help a little bit. But this is going to be, I'm going to say, connect with a physician with experience with post-acute COVID syndrome. And there's a lot of centers throughout the country. And they can hopefully help you really pin down what's going on. If your doctor is not interested, find a doctor who is.
Gretchen writes, you said the data from the UK household transmission study was a bit underwhelming, with maybe only a 40 to 50% reduction in transmission. However, you attributed that outcome to the fact that many in the UK had only one jab. Are there any studies that show how much household transmission is reduced when a family member gets both doses of Pfizer or Moderna? If so, how much is the household transmission rate reduced with the 2-jab mRNA vaccines?
Yeah, so I don't think we really have the high quality evidence that I would like to address that issue, and I think it's really important. And there's several levels to it, right? One is going to be, going to be over time, right? So you've just gotten your 2 doses, you're 2 weeks out, you're 3 months out, you're 6 months out. Does that number change over time? Because we think the getting infected and transmitting is going to be at the surface. The mucosal level is probably going to be very dependent upon antibody levels, while serious infection, we think severe disease, is probably more related to T cell effects. So we really don't have the data in the detail that I would like to really understand what impact will vaccination have on community immunity or herd immunity over time.
She also wants to know if you know differences in transmission between vaccinated children and vaccinated adults.
So we do think that there is more transmission among adults, interesting enough, little sort of a twist on this virus versus so many others. What we saw, right, and I think I mentioned this a little bit earlier, is the Pfizer study on adolescents. Nobody was PCR positive. Pretty hard to transmit if you can never turn PCR positive. It'll be interesting to see what that durability is in children. But it's sort of a continuum that we've seen over all our sort of understanding of immunology and vaccinology. A younger individual has a more robust response to vaccines than an older individual.
Pamela writes, I have a close friend who lives in Rhode Island. We spend part of the summer taking car trips together, visiting each other. Since she will not get vaccinated, she says the vaccine is synthetic. I come from a family of virologists, and honestly, I can't even go there. I don't feel comfortable on extended car trips or house visits. I've had 2 shots of Moderna in March and April. I've told her we can have a meal outside. She can stay downstairs distance if she needs to. She's not concerned about herself, but I am worried. I'm 73 and healthy. Do you think that car trips and extended non-distance house visits are safe to resume?
It's going to be this judgment. And I think, it's the bulletproof vest. Are you willing to let someone take a shot at you from 100 yards? They'll probably miss. But you've got to ask, you're 73. The vaccine in you is not going to be as robust and protective as it is in a younger individual. So if you're in that car and, should that other individual actually be infected, you're at risk. Your risk is reduced, but we talk about like that 6 feet of distance, that 15 minutes. But if you're in a car, you're really, really increasing your chance. So even if you reduce it only by 88%, that's a 1 in 10 chance. You may not want to take that chance. I know I wouldn't want to take that chance.
Our last email is from Tony. You and others on TWiV state that COVID and long COVID is a risk to children. They should get vaccinated. However, you never compare the risk of COVID and long COVID to a healthy child with the risk of vaccine side effects. I support vaccination, but please spend some time making this comparison. It would address an issue often raised by anti-vaxxers. My own view is that vaccinating children is more about combating the virus in general and not so much about protecting individual children.
So thank you for we'll close on this because I think this is really important. Our lowball estimate from our studies on children with relative risk of long COVID, about 1 in 25, maybe 1 in 50, which is pretty significant, compared to, let's talk about our different adverse events. So the risk of 2 days of myocardial inflammation, 1 in maybe 100,000. The risk of clotting, we're getting up in, again, hundreds of thousands, risk 1 in a million. So those are kind of the numbers. We're talking about, at this point, your child's either going to get the vaccine or COVID, just a question of time. 1 in 25, 1 in 50, maybe even higher compared to the risks that we do know are incredibly low with vaccines. So that really is a perfect question to close on, because that's really the choice we're making.
That's a special COVID-19 Q&A with Dr. Daniel Griffin. Thank you, Daniel.
Oh, thank you, everyone, and everyone be safe.